Hello, everyone. My name is John Riggi. I'm the National Advisor for Cybersecurity and Risk at the American Hospital Association. I'll take a moment just to give you a little bit about my background. Prior to joining the American Hospital Association, I was in the FBI, served in the FBI for over 28 years. And in my last role at the FBI, I was a senior executive in the cyber division, where my job was to help create mission critical partnerships with private sector, including healthcare sector. In fact, healthcare sector was one of the primary critical infrastructure sectors we focused on because we understood its importance, its role in preserving public health and safety. Having this role as a national advisor has afforded me the opportunity to have thousands of candid and confidential conversation with hospital leaders around the country. And unfortunately, this role has also afforded me the opportunity to have conversations with hospital leaders from dozens of hospitals and health systems which were victims of ransomware attacks, and understanding some of the vulnerabilities that led to those attacks, some of the best practices that helped in their recovery, and some of the challenges they faced in responding to the attack. It's become quite clear to me, as I've been saying for years, that cyber risk is not just an IT issue. It is an enterprise risk issue. It is a strategic risk issue. And most importantly, it is a risk to patient care and patient safety. When it comes to cybersecurity, we've come to learn that although protecting the privacy and security of patient data is very, very important, it's secondary to actually protecting the patient and ensuring uninterrupted care delivery. Cyber hygiene is as important as medical hygiene to protect the patient. I think we all have a sense that cyber attacks have increased very dramatically over the past couple of years. But how bad is it for healthcare? Is it just our perception, or are we really under siege? One measure of the level of cyber threats we are facing is the number of breaches that have been reported to the Health and Human Services Office of Civil Rights portal. Here, all breaches impacting the privacy or security of protected health information must be reported by any HIPAA-covered entity within 60 days. So I took a look at it this morning, calculating the number of breaches reported in 2021. And what I looked at was just the hacks. So there's a number of categories that are reported to HHS, which also include non-malicious compromise of protected health information, such as when patient data is inadvertently emailed unencrypted to an outside entity. So for the year of 2021, as of this morning, there were 518 hacks reported impacting 42.9 million individuals. So this is out of a total of 45 million individuals being impacted, even from those non-malicious breaches. For comparison, in all of 2020, there were 425 breaches impacting 26.7 million individuals. So even at this reporting point, we are at 160% of the breaches in 2020. And again, I just looked at the external hacks, which have constituted the majority of these breaches that are reported. One of the reasons why hospitals and health systems are being targeted so much is because of the value of protected health information in terms of it being sold on the dark web. Protected health information commands a much higher price than other types of stolen information like credit cards. And one of the reasons for that is that protected health information has enduring value. Unlike a credit card number, which can be canceled and reissued, you can't cancel your diagnosis. You can't cancel your x-ray and have a new one reissued. So it has enduring value for the bad guys. But we also have personally identifiable information, we have payment information, and we have medical research and innovation. So all these data sets are uniquely valuable to cyber criminals for them to steal and monetize. When you put them all together, they become exponentially valuable. But one of the main cyber risks that we are most concerned with are high impact ransomware attacks. resulting in a local, regional, or statewide disruption of care delivery and risk to patient safety. We have seen an exponential increase in ransomware attacks since the pandemic, interrupting and delaying urgent care delivery, including emergency care. Why is this happening? In response to the pandemic, hospitals rapidly deployed and expanded network connected and internet connected technologies to accommodate the surge of COVID patients and a remote administrative workforce. So what this did, it create many more opportunities for bad guys, foreign-based cyber criminals to penetrate our networks. It's what we call an expanded attack surface. And the bad guys that I'm referring to are international organized crime groups, primarily based in non-cooperative foreign jurisdictions, primarily Russia, and nation-state foreign intelligence services belonging to the states of Russia, China, Iran, and North Korea. So when we talk about risk exposure to ransomware attacks, it's not only through attacks being conducted, targeted directly at the hospitals and health systems. Hospitals and health systems are being exposed to ransomware attacks and cyber risk through third-party relationships that they have. For instance, we're all aware of the Kronos attack, which recently occurred. So they were a mission-critical third-party provider for many hospitals and health systems across the US. And although hospitals were not directly targeted in that ransomware attack impacting Kronos, hospital and health system services, administrative services, were disrupted in relation to scheduling, timekeeping, and payroll, which certainly could have an indirect impact to care delivery functions. But again, the most serious risk that we're concerned about through ransomware and other cyber attacks are risks to patient safety, which may result in emergency departments being shut down and ambulances being placed on full divert, so thereby causing a delay of emergency treatment. We've seen trauma centers availability limited and resulting in a regional impact. Telemetry systems becoming inoperable, radiology, imaging, PACS systems being down. Of course, if the electronic medical record is not accessible during a ransomware attack, that creates other issues and potential care delivery and safety issues. For instance, in terms of identifying drug allergies or interactions, or unknown courses of treatment, in which result in a delay in rendering care. Again, those lab results unavailable. We've seen surgeries being canceled, and of course, admissions, discharge, and transfers being affected as well. We've even seen that the drug cabinet systems are down, home telemetry disrupted. There is another effect, is what I refer to as the ransomware blast radius. So other providers who may depend upon the victim hospital for an emergency department, electronic medical record, labs, imaging, cancer treatment. So those entities which depend upon the victim of ransomware for those services also suffer some type of repercussion or ramification from the ransomware attack on the main victim. Again, that ransomware blast radius. So we've also seen, as a result of ransomware attacks, a complete loss of all network and internet connected operational, informational, and medical technology, including even the downtime computers, which are present in many organizations, which were thought to be able to be relied upon during a ransomware attack, were not available, because those downtime computers do periodically connect to the network for update, and the ransomware is able to locate those computers and encrypt them as well. One of the most significant findings we're seeing is that in terms of ransomware readiness, is that there is a tremendous gap between perceived proficiency of staff in clinical downtime procedures and actual proficiency. We're seeing that staff are unprepared for extended clinical downtime procedures in paper charting lasting up to 3 to 4 weeks. So what we have seen is that generally the more experienced, I don't want to say older staff, but the more experienced staff that have had direct experience in manual charting and documentation are able to handle these downtime procedures more proficiently. But again, what we're really concerned about, we're most concerned about resulting from ransomware attacks is the delay and disruption in the deficient delivery of medical care. Now, we always say that this increased the risk of negative outcomes, risk to harm of patients. And many folks have said, yes, but can we attribute deaths to a ransomware attack? Our response has always been, do we really have to show specific deaths? Isn't it enough to show the elevated risk that the delay of urgent care creates rather than the actual physical harm? Well, unfortunately, we may actually have some proof from the government of actual physical harm and deaths tied to ransomware attacks. The DHS Cybersecurity and Infrastructure Security Agency recently published a report which correlates excess deaths on a regional and statewide basis directly to ransomware attacks at hospitals and health systems during that time frame. So they subtracted the COVID deaths. They understood what the normal deaths were, correlated unexplained excess deaths at the time of ransomware attacks in a particular region. So very concerning, and again, but not surprising when you delay and disrupt patient care in emergency treatment during a ransomware attack. These findings really aren't surprising, as disturbing as they are. So some of the lessons learned and some of the observations and recommendations that we're providing to hospitals and health system leaders during attack, post-attack, and as part of our process to help them exercise in preparation for these attacks. One of the things we always say, no matter how much financial, human, and technical resources you devote to cybersecurity, you can never eliminate the risk. You can only help to mitigate the risk, and you need to be prepared for that eventuality when a disruptive cyber attack occurs. So one of the first things we always recommend is that hospitals and health systems develop and document and disseminate and exercise an overall business continuity plan for all the functions. And that plan should consider business continuity under circumstances involving a complete and simultaneous loss of all mission critical medical information and operational technology. So that business continuity plan for each function should be reviewed and then integrated into the overall incident command structure. Of course, what we also recommend is that the cyber incident response plan be regularly updated, integrated, and regularly tested as part of the overall emergency management incident command function. We also recommend that staff themselves are continuously and appropriately sensitized as to the nature of IT incidents and how to report those as soon as they discover them, because that might be what the activity they're seeing might be a precursor to a potential ransomware attack when the bad guys are doing what we call a reconnaissance or a probing of the network. We also recommend that hospitals and health systems identify and exercise what the triggers are which would cause the overall incident command structure to be activated. So when developing in the cyber incident response plan, we talk about developing a phased approach which helps bolster readiness, response, resiliency, and recovery. It's the 4R concept. So we talk about developing, again, based upon real world incidents, and now that we have these case studies to refer to, developing actions which should be taken to sustain business continuity in clinical practices, care delivery for the first 24 hours, then short-term actions, 24 to 48, intermediate, 48 hours to 1 week, and yes, long-term clinical downtime procedures and other downtime procedures for all mission-critical functions lasting 1 to 4 weeks, potentially longer. So what we've seen is it takes up to 3 to 4 weeks, actually I would say minimum 3 to 4 weeks for organizations, for victims to restore those mission critical clinical functions after a high impact ransomware attack. Actually takes even longer for other business functions, such as like administrative functions and payroll, for instance. But we also talk about developing these processes and procedures, not in a silo within your own organization, but developing them on a regional basis. So now we talk about the 5R concept, having plans developed, including communications plans to further bolster regional readiness, response, resiliency, and recovery for a regional high impact cyber attack or ransomware attack. So the plan should consider the contingencies to accommodate possible diversion of patients and functions between hospitals in a given region. Communications is always a critical function and could be an Achilles heel during these critical incidents. So we really strongly recommend that organizations review their internal crisis communication plans and platforms to accommodate emergency and secure two-way communications. It is also recommended that this feature be tested on a regular basis via off-network access and for off-hour response by staff. Are folks picking up their phones? Are they answering at 2 a.m. on Sunday morning when most of these attacks occur? And again, I think one of the principles here for emergency communications is to ensure that you have triple redundancy in place for emergency communications. And then we talk about the identification and documentation of which roles have designated and delegated authorities to make independent, high impact decisions, such as who would make that decision to disconnect the organization from the internet or shut down large parts of the network, and then understand what the impact, what the clinical impact of that decision would be. So are those cascading effects mapped out? And are the clinicians, the administrators, information security folks, all in agreement and understanding when that decision should be made and what the impact would be, not only internally, but also externally, understanding what that third party impact would be if an organization decides that they have to shut down parts of the network or disconnect from the external internet. And really, that comes down to identifying the impact to life critical and mission critical devices and services if the network or internet access is lost. And then again, determine the impact of the clinical, IT, and operational cloud-based and electronic medical record services and applications due to loss of the internet and network connections. So some of the other clinical decisions that we've seen organizations have to make, or I should say clinical related decisions that organizations have to make during these high impact ransomware attacks and really need to be defined on a department level, a hospital level, and a system level related to, for instance, ambulance diversions, admissions, discharge and transfers, elective procedures, outpatient radiology, and also to determine what the process is, what the decision will be regarding the continuity of care procedures for radiation oncology and chemotherapy patients, and identify and document what the triggers would be for crisis standards of care under these circumstances. So again, I can't stress enough that downtime procedures training for staff for loss of all medical technology such as telemetry and PACS and radiology really has to be a focus for the organization in preparedness and response. And not only training for downtime procedures during off hours, which is the point that which most of these downtime procedures testing is occurring, we're finding, but really to test even during peak hours and on the day shift. It is also recommended that downtime coaches and separately downtime safety officers be designated for each department and each shift. Because what we're finding is that it's almost impossible to train every new staff member to a very proficient level in downtime procedures. So maybe it's best to have a coach who's present on each shift that can help manage the downtime procedures during an emergency. And those downtime safety officers also be present, separate role, since you're going to lose those built-in safety procedures in the electronic medical record, such as the EMR automatically flags drug allergies, drug interactions, and prescribes courses of treatment. That's why it's best to have that second set of eyes as a measure of safety, patient safety. We've also found that once there is a loss of medical technology, that technology has to be replaced with staff, with humans. But of course, where are the schedules and the contact numbers? Often they are electronically maintained, so which creates another cascading crisis. How do we reach our personnel when we need a staffing surge? For that matter, how do we track all the patients that we have? What is the patient census? So we would recommend that paper copies for all the staff shift schedules, staff contact numbers, patient census be available and accessible for each shift in the department. Based upon our experience and what we've seen during these ransomware incidents, is that we recommend that organizations also develop a ransomware or cyber incident communication strategy that has in place internal and external communication templates, including social media templates, to distinguish and harmonize communications for staff, patients, and the general public, including federal and state regulators. And really, the organization should determine the general cadence of communications and identify who will be the public face of the organization during such a crisis. Also, what we have found is that there is an immediate need to identify mission critical third parties, including cloud and technology providers, and determine their clinical, operational, and informational technology impact if you're struck with ransomware or if they are struck with ransomware. What services become unavailable? Again, what is the impact to patient care delivery? Again, and develop those business continuity plans for impacted function based upon a loss of third-party mission-critical services. I think what we'll stop there for now, because that is a lot of information, but kind of gives you an overview of some of the type of cascading effects and issues which will arise as a result of a high-impact ransomware attack. So before I conclude on this portion, I'd like to thank all of you for allowing me the opportunity to speak to you today, and thank you for all you've done during the pandemic and now to care for our patients at great personal risk and sacrifice.